for the session. Dr. Pinto is the Chief of Cardiology and Director of Cardiac Catheterization Laboratory at Holy Family Hospital in Bandra. He's also attached to Breach Candy Hospital, MGM Hospital, Vashi, Sefi Hospital, and Nanavati Hospital as visiting interventional cardiologist. He's one of the pioneers of the transradial approach to cardiac interventions in India. He has been a teacher of DNB cardiology since 2007. He has conducted many conferences in cardiology and also several publications in API textbook, IHJ, etc. As faculty member, he has frequently performed live case demonstrations at events such as India Live, Malaysia Live, CSI, TCT Washington, and Asia Pacific. He's involved in numerous clinical trials and registries in cardiology, like the Oasis 7 and 8, On Target, Signify trial, and the various other trials. So I would like to welcome him to the stage.
Thank you. Thank you, Pandey, and thank you all the remaining speakers who allowed me to come and speak, Raju Karnik and so on and so forth. I need to go. I'm not an expert on PCSK9. I'm not an expert at all on much of lipidology. I don't know what an interventional cardiologist is doing over here, but I think we all need to understand this new molecule that is coming in to our state. But I'd like you to concentrate on this first slide extensively. The reason being, just look at the cholesterol values that we have in newborn individuals. You can see that it is not more than 40. Look at what happens to heterozygous individuals. Cholesterol values, LDL values above 300, homozygotes above 700. Look at the other animals that we have, all cholesterol values below 25. And somebody asked a question during the last or the previous talks and said, what would happen if your cholesterol value falls below 40? Would you have neurological events? And there was a feeling that some kind of bleeds or some kind of things could occur. However, in many of the studies, it has been seen that these events are very rare. And actually, dropping cholesterol values to your neonatal values, which is in the region of about 40 milligrams per deciliter, is not harmful in most individuals. What I think we need to concentrate on when we look at this particular slide is to look at individuals who are at very high risk and extreme risk. And these are groups of individuals where we can see, for example, that we don't really look at patients who have CKD as very high risk. Very often we just ignore them. We just think that these are not very high risk individuals. Similarly, patients who have had an ACS, these are extremely high risk individuals, and most of the times we think that cholesterol or LDL values in the region of 70 to 100 are adequate for them. However, as the event rate shows, these individuals actually need their cholesterol, their LDL cholesterol values to be in the region of 50 or less. The extreme risk individuals are those who need to have their values much lower than what we achieve with statin therapy. And so many of them are actually individuals whom we see in our clinical practice, patients who are diabetic with CKD, patients who had an ACS, so on and so forth. And therefore, if we look at all the recommendations now, the recommendations are becoming much more stringent, especially in extreme risk individuals, where in spite of a cholesterol value, an LDL value of 70 milligrams per deciliter, these patients continue to have events. So what happens to your situation when you have a patient whose LDL is 70, continues to get an ACS event? I think we do not take those values seriously enough. So this is where we need to look at extreme risk individuals, high risk individuals, heterozygous individuals with familial cholesterolemia, and the homozygous, of course, go off even much before we did. So even the Indian Association of Lipidology, the Lipid Association, has said that extreme risk and high risk individuals need to get a LDL cholesterol in less than 50 milligrams per deciliter. And how many of us with statin therapy alone can achieve this value? Now look at our status in India. Look at our status all over the place. If you can see that in patients who were treated, the Indian data, less than 8% of the patients actually achieved the lipid goals. Of these it was seen that a few females and a few males did that, but this was only 226 patients out of a value of almost 2,700, 2,900 patients. You could see that only 216 patients or 226 patients achieved the lipid goals that were recommended. And most of us think that familial heterozygous hypercholesterolemia is uncommon. If you speak to Dr. Sani, I think he's already left, it is 1 in 500 people, and in fact, in Asian population, this is even more. So if you were to consider familial heterozygous hypercholesterolemia, this is not an uncommon finding. This is seen quite commonly in people, and very often we ignore this. So this is the Simon-Broom criteria for picking up familial hypercholesterolemia. You can see that if you have 1 plus 2, that is more likely, for example, total cholesterol values which are above 290, that is 7.5, that is, and you have tendinxanthomas, DNA-based. So if you look at these criteria, and you can then pick up patients who may have familial hypercholesterolemia. So all of us must concentrate on people who have very high values, and these are the patients who may require the PCSK9 inhibitors, because you are not going to get the values with statins alone. So this is the Canadian cardiovascular position as far as familial hypercholesterolemia is concerned, saying that you can make a genetic diagnosis or you could make a clinical diagnosis. And besides the dietary pattern and lifestyle, you must consider other pharmacological means to treat this. So I thought I'd bring up a case and, present a case to you of a 48-year-old gentleman, type 2 diabetes, EGFR of about 40. So he's got CKD. His total cholesterol is 170. He's had unstable angina. He had triple vessel disease on a coronary angiogram, LVEF of 45%, and a blood pressure of 130/80. So here was his medications that were on. He had statin, he had sartan, he had amlodipine, and he had 2 anti-diabetic drugs. As you can see, his creatinine value was elevated when he came to us at that point in time, and his total cholesterol was 166 with an LDL of 86, and this was his lipid profile, triglycerides slightly higher. So I'm going to pose a question to you after this. He was then given aspirin, ticagrelor, fondaparinux, and an angioplasty, angiography, and PTCA to his LAD was done. Now, here you can see that I'm asking you, what do you think this LDL goal of cholesterol should be? Now what would you rate this individual to be? I would possibly think that he would be considered as a very high-risk individual. CKD, had some diabetes, was also in a situation where he had an ACS. So obviously, I would shoot for 50 as his goal of LDL cholesterol. Would somebody disagree with that? Samir, would you say that you would try to shoot for a goal of 50, or would you shoot for a goal of 70?
Lesser than 50.
Lesser than 50. So I think clearly today our data is to suggest that these patients now would like to have. So another question to the audience, once again, we do not have those answer pads, but would you leave him on the current regime which you had over there, increase his dose of statin, move to a more powerful statin, and either increase dose of, increase the dose of atorvastatin and add ezetimibe as well. So, once again, I would say that we would possibly, increase the dose of statin to 80 milligrams and add ezetimibe to this particular individual, and then we continued his treatment. Now, why did we do that? Why did we do that? This was the IMPROVE IT study, which clearly showed that when you had simvastatin, because it was used in patients with simvastatin, almost 18,000 patients, you could see that the event rates came down significantly, clearly proving at this point in time that adding some kind of therapy over the statin therapies, this was a non-statin therapy which was added to a statin therapy with the intention to treat over a period of 5 years, and you could see that the benefit was seen, and clearly we did that. So this was clearly trying to show you the benefits that adding ezetimibe. So today in India, when we have a patient on a statin therapy which is not bringing down his LDL to goals without the availability of PCSK, we clearly add ezetimibe, and this is better. Now, after we did that, we found that his values had come down. His HDL also came down a bit, but his LDL came down to 70. This was after a 6 to 8 week period, and he was once again investigated, but his RCA had another event, and his RCA lesion had progressed. This was treated again with angioplasty. So want to ask you now that would you like to change to rosuvastatin or add PCSK9? And I'm once again asking, we don't have the panel over here. So Samir, at this point in time when this patient had an event over here, would you consider what would be your, if we had PCSK9 with us?
So I understand because the choice has changed to rosuvastatin oblique add PCSK9.
Now this guy's got an event again, in spite of his LDL cholesterol having come down to 70.
With 80 milligrams of this
Yes,
plus ezetimibe.
80.
Now his EGFR, if I am not wrong, you said was 40.
His
EGFR.
EGFR was 40 and came down to in fact 25. So you have a problem over there.
So I have major problems with rosuvastatin.
Yeah.
So that is the reason why probably PCSK9 becomes a choice for him.
And we thought the same way. We thought the same way that at this point in time that possibly rosuvastatin would not be a great choice. And so what will happen if we reduce his levels to below 50? And we did that. Actually, we added up PCSK9, but to reduce the levels to 50, many of the people think that the events are reduced actually by more than half if you reduce the levels to less than 50. And this is clearly to show you that in spite, I think in the absence of a better target, we do not have today a better target than LDL. Unfortunately, we do not have that. And so in this event, you could reduce your levels to below 50 and possibly reduce events even further. Now, despite low LDL cholesterols, clearly it is seen that high-risk and extreme-risk patients continue to get events. And therefore, it is clear to us right now that one of the important discoveries is the addition of PCSK9. So we did that, but then brought down his cholesterol further. His HDL came down a little bit, but his LDL came down to less than 45. So what are these PCSK9? I think JP Sani mentioned to you what they are all about, but they are a new class of drugs. They basically are there in the hepatocyte and they bind to LDL particles. They remove the LDL particle. They remove basically in the circulation. What they do is they hold on to the receptor. The receptor holds on to the LDL particle and comes within the cell. Then the PCSK9 holds on to the receptor and does not allow the receptor to come back to the surface. So there is an inadequate return of the receptor to the surface site. Now, when you have an inhibitor of the PCSK, which occurs at this level over here, the receptor is allowed, the LDL receptor is allowed to come back to the surface, once again improving the removal of LDL particles from the blood. So PCSK9 inhibitors, by inhibiting PCSK9, allows the recirculation of the LDL receptor to come back to the surface and in that way reduce the LDL. So this is seen in a genetic population as well, who have a deficiency in PCSK9. Those who have a deficiency in PCSK9 actually have a greater removal of LDL particles, and therefore LDL levels are pretty low in those patients, and these patients continue to live long lives. So what about the long-term efficacy and safety of the PCSK9 inhibitors? So you had very large trials. There was one trial, which was the Odyssey trial, which was done in patients with alirocumab, where you had patients above the age of 40 years who were hospitalized with ACS in the past 4 months, and this was compared to placebo. And the second was the Fourier trial, which was taken in patients who had very high risk, 40 to 80 years of age, cardiovascular disease at very high risk for recurrent events, and the fasting LDLs were more than 70. And these were given either a single dose of the evolocumab or a double dose, that is 140 milligrams, were given twice a month, and this was compared to placebo, and the endpoint was time to CV death, MI, hospitalization, unstable angina, so on and so forth. And this was how this panned out. It panned out to show you that there was a significant reduction in events when you drop the LDL cholesterol values by a significant amount. As you can see over here, that the event rates came down significantly when you had a reduction in the cholesterol. And what these drugs did, that over and above the statin, they dropped the level of cholesterol by more than 60% in a good number of patients. This was the Fourier study to look at how the event rates dropped. You could see that there was a 2% reduction. There was a 2% absolute risk reduction when evolocumab was used over and above placebo. These were on top of patients who had already received statin therapy. And this was for both for the primary endpoint as well as for the secondary endpoint. You can see that there was a significant reduction in the overall rates of endpoints. The Fourier evolocumab study showed that there was a 54% reduction in LDL cholesterol compared to placebo when you use this drug over a period of time. And the Osler looked at the adverse events, and you could see that in spite of the levels of LDL cholesterol dropping to less than 25, 25 to 40, 40 and above 40, there was no significant serious events that occurred. So there may be even neurocognitive events were not significantly more. The enzyme elevations were not significantly more. The only minor side effect that was seen when these drugs were given were an injection site irritation that was seen in these patients. So these were the event rates. You could see that in most of these trials that the reduction was very significant, ranging from about 45% to almost 66% for patients who received this drug, either of these two drugs. And these were once again to show you that compared to ezetimibe, the reduction in the two monoclonal antibodies that reduced the drug. And this was how they were administered. Evolocumab was administered either single daily dose or twice. And this was the effect that you could see in non-familial as well as familial hypercholesterolemia, that in high-risk patients and in patients with familial hypercholesterolemia, there was a significant reduction in the levels of the LDL cholesterol. Now, lipid-lowering therapy given in these patients, the method of administration is given over here, either as a single monthly dose or bi-monthly dose, as can be seen. So what was the impact? What was the health impact in these patients? Use among 27% of the population with elevated blood cholesterol values. So in the US, they found that possibly the effect that it came in terms of dollar rate was not adequate. They have a particular value to calculate this. And they found that maybe the expense, because it costs in the US double of what it is going to cost in our country. We are going to get this drug very shortly in our country, and they find that in the US, they did not find this to be, really of that significance. So cost of therapy in the US is approximately $14,000 per year, which is about 10 lakhs of rupees. In India, the cost is likely to be about half of this, somewhere in the region of 4.5 to 5 lakhs of rupees. We will have to look at patients who will benefit the most. Is it prime time for India? We do not know that. Is it required for a certain group of patients? Certainly it does. For patients who have familial hypercholesterolemia, patients who are statin resistant, patients who cannot tolerate statins, and patients who continue to remain at extremely high risk or high risk in spite of statin therapy, I think this will be the group of patients. So this is how post-ACS-CAD patients are there. If your levels are still remaining above 70 in spite of statin therapy, your first step would be to add ezetimibe or optimize statin therapy first. Secondly, you add ezetimibe. And thirdly, you add PCSK9 inhibitors in those groups of patients who continue to have events in spite of the fact that you have put them on adequate doses. LDL, as you know, should be the primary target for therapy because in the absence, maybe inflammation will be a therapy, will be a form of, when we come to drugs like canakinumab, which have shown a further 14% reduction in event rate when they were added to statin therapy, will be another target when the CANTOS trial, as we saw. One thing we can say is that LDL levels below 50 milligrams per DL are certainly extremely safe. And many patients in India are still not at goal. LDL, as we mentioned, was the target of therapy. In patients with familial hypercholesterolemia, difficult to reach a goal of 50, but it's possible when you have other agents like PCSK9, and combination therapy with statin, ezetimibe, and PCSK9 may be the way to go in high-risk patients and in patients with familial hypercholesterolemia. Thank you very much for your attention.
Wonderful disposition. Thank you, thank you. The paper is open for discussion. Anybody from the house?
Yes.
Well, please enlighten us about PCSK9 inhibitors and CKD. Up to what stage of CKD it can be given? This is my first question. And what are the definite contraindications of this molecule? In which patients it is better avoided?
Does somebody else want to take that question? Because I have no idea about the action in patients who have got CKD.
CKD, sorry, you want
yeah.
to take?
Is allowed.
PCSK9, they have not
Inhibitors.
eliminated patients restricted with whether it was in Odyssey or whether it in Fourier or whether it was in Osler. They have not eliminated people who were there. The problem which has occurred is not because of the CKD. The one which people are kind of underplaying is the neurocognitive problems. Neurocognitive problems with PCSK9 inhibitors are almost 3 times. Though they have underplayed saying that they don't really cause a day-to-day problem in activities. Their higher functions in calculations of mathematical equations, etc., may be a little hampered. But otherwise, they are kind of underplayed. Sir?
Basically, if you divide into three groups, one is CKD, second is the one who is on hemodialysis, and third is the one who has got renal replacement in the form of kidney transplantation. So in CKD, it is recommended that it has the benefit, we should continue. In people who are on hemodialysis, there is a clear-cut statement that it was not so useful and it may not be given. And again, after the transplant, it should be given. I mean, this is what is
I'm
given
not too sure whether they considered CKD5 in any of the studies.
It is a recommendation.
That in CKD5,
No benefit. In
CKD5.
HD, no benefit. In CKD, there is a benefit. In HD, there is no
So
benefit.
after transplant to be used again?
Yes, you can give it.
Have you used in how many patients and what is your experience?
No, we have not, PCSK is not available in our country. We were part of the trial, but we didn't really participate very much because basically it was very, very expensive. And what happened was that we didn't take part in that particular trial. They had encouraged us initially. But I have the data from JPS Swani, who has quite a lot of effect. So he says that they had very good lowering of the LDL cholesterol. However, the effects that were seen, the long-term effects, we do not know whether, these patients have got, except from the trial data shows us that there is a reduction in event rate, but we have to look at it over a long period of time. Personally, we have not used PCSK9 ourselves.
Regarding side effect and drug-to-drug interaction?
See, as far as side effects are concerned, as mentioned over there, some of the things that we said were the neurocognitive effects that happened with this particular drug. But in the trials, what they mentioned was there was no significant increase in the enzyme levels. There were no significant increase in any of the other side effects other than the injection site problems that occurred with these patients.